Hello friends, and welcome back to my YouTube channel Malik Helps. So in this video we are going to talk about the inflammatory bowel disease, under which the categories are the Crohn's and ulcerative disease, pseudomembranous colitis. We are going to talk about the UTIs, which will be cystitis, pyelonephritis. We are going to talk about the glomerulonephritis, under which the category is nephritic syndrome and nephrotic syndrome, and we will see the stages of syphilis along with the questions over it. So let's start. So before talking about ulcerative colitis and Crohn's disease and pseudomembranous colitis, let's just have a short look over the blood supplied and lymphatic drainage of the colon. So as we can see in the highlighted picture, this is the picture made by me for you. We can see that there are the abdominal artery aorta divides into two parts, which is SMA and IMA, like the superior mesenteric artery and the inferior mesenteric artery. So superior mesenteric artery will supply the it will be further divided into the divisions. One will supply to the cecum, which will be ileocolic artery. One will supply to the renal colic artery, and some part of the transverse colon will be supplied by the middle colic artery. And inferior mesenteric artery will be divided in the portions left colic branch and sigmoidal arteries and some superior rectal arteries. So rectal supply is also done by the inferior mesenteric artery. You can see the highlighted parts, and let's read the text with me. So some part of the colon is foam, midgut and some hindgut, so up to distal part of transverse colon. Midgut give rise to second part of the duodenum, jejunum, ileum, cecum, ascending colon, and some part of the transverse colon. Guys, this is the development of the gut, that how the gut is got developed. So this is the portion, and let's see the supply. So superior mesenteric artery, as we know, so is further divided into the ileocolic artery, right colic artery, and the middle colic artery, as you can see in the pictures highlighted with the red text. And the next is inferior mesenteric artery. So we know from now that inferior mesenteric artery will be divided into left colic branch, sigmoidal arteries, and superior arteries, as you can see in the picture. Again, you can take a screenshot of it to remember for the long-term memories. And lymphatic drainage, as we see, so there are three type of stations are there. I'll let you know another things about lymphatic drainage, but just for this part, first station is epicolic, which will supply the epicolic part, and second station is along the blood vessel, which will drain the blood vessels lymph. The third station is at the root of the superior mesenteric artery and the inferior mesenteric artery. So third station is here, as you can see in the picture, that it is near to the superior mesenteric artery, right? And in the second station, you can see is second station is what it explained, along the blood vessel. So as soon as the superior mesenteric artery is divided, the second channel is here on the further division. And the first station, as you can see, is epicolic, which will drain the lymph from the colic region, or let's say epicolic region. Yeah, so take a screenshot and read the text well. You will remember it very well. This is the chronic condition, refers to the inflammation of the GI tract. So here are the layers of the GI tract. That innermost layer is mucosa, outermost layer is serosa. Inner to outer and outer to inner, howsoever you like to remember. IBDs are caused by autoimmune, genetic conditions or environmental factors, and mucosa is the innermost layer. Remember, the serosa is the outermost layer. However, they are in a series, that inner to outer. So mucosa, submucosa, muscularis, serosa, adventitia. So let's see, Crohn's disease is the disease which will affect any part from mouth to the rectum. This is the main thing you have to remember in the question. However, you can see the symptoms in the bowel movement changes. The treatment for Crohn's will be mesalamine. So corticosteroids, since it is an immune related disease, so we will just want to suppress the immune and problem will be solved. Ulcerative colitis is something which will affect only the colon and rectum, and we can prescribe mesalamine or mesalazine to the patient easily. Sometimes the question will be given on sulfosalazine, so you remember from the suffix here that Crohn's is the problem related to the mouth and anus, any part of the GI tract, and ulcerative colitis is specifically the problem with the rectum and colon. As the name suggests, that colitis is the problem with the colon and rectum. So let's hear it from the patient. The first patient says the terminal ileum is thickened. So this is not the involvement of the colon, not the involvement of the rectum. The involvement of terminal ileum with the serosa is covered with the grayish white exudate. So we remember from the definition portion that ileum is there, so we are going to go with the Crohn's disease of terminal ileum, and some adhesions are over there as well in the question. Next patient says directly about the rectum and colon is painful for him, so it is ulcerative colitis. Next patient also says about the sigmoid is painful and spastic, non-ulcerative colitis. You will remember it from here that colon and rectum are the things, or the finding, the inflammation related findings are related to the ulcerative colitis. Let's see the next patient also says about the sigmoid colon is spastic. No need to mix it with the Shigella. I have explained in another video. Actually in Shigella as well the sigmoid colon is painful, but why, sir? How we are going to mark this now if in both the pathologies, if the sigmoid is spastic, how we are going to know? So how you will know that Shigella is an infection? So it will give you the fever and many more symptoms related to the infection findings, like the asthenovegetative findings. Sigmoid colon is painful here, sir. So what you have to remember in the question, weight loss is not the character of Shigella. Liquid stool is also the character of Shigella, but sigmoid is spastic, plus we can see that the condition is autoimmune here, that no fever is given in the question, so this is not an infection. This is the case of ulcerative colitis. And as you know that sigmoid is spastic, so you are going to mark the ulcerative colitis for the question. Next is pseudomembranous colitis. The treatment of choice for pseudomembranous colitis is vancomycin. So this is the inflammation of colon caused by the outgrowth of Clostridium bacteria. So in the question they will give you the history of this recent antibiotic abuse or use, howsoever you understand it better way. So symptoms, you can see bowel movement changes in the patient. Yeah. Diagnosis, how to diagnose this condition? The recent antibiotic use plus the endoscopy findings will say to you that it is pale yellow pseudomembrane like coating over there. So let's hear it from the patient itself. The patient says 2 week after an antibacterial therapy, the patient had this and this bowel movement changes and abdominal pains followed by the elevated body temperatures. Remember that this is colitis, this is inflammation. Itis is inflammation. So the question will give to you the fever as well, yeah, which is highlighted by the patient itself. And prostosigmoid colonoscopy findings are mucosal lesions plus pale yellow coating. So we remember from the definition portion that pale yellow findings are related to the pseudomembranous colitis. Another, once again, the treatment about both of them is you can easily prescribe mesalamine, mesalazine and sulfosalazine to the patient easily. I hope this is clear now. Next is about the urinary tract infection. So urinary tract infection occurs when the bacteria infect any part of the urinary system, including the kidneys, bladder, uterus or urethra. And the symptoms which we are going to see in the patient are urine related. So there will be fever because they are infections. There will be weakness in the patient, pain or pressure in the lower abdomen due to bladder infection or any another kind of lower pelvic infection. Strong or persistent urge to urinate and burning sensations. A lot of things will be given in the question. Let's say cystitis especially. Let's see what I have wrote in this corner. Okay, after the definition, so inflammation of bladder, which is most commonly caused by bacterial infection, irritation, or sexual activity. So inflammation can occur with the sexual activity itself, right? If the activity is vigorous, then it can occur inflammation. Any infection can cause it. So let's see, symptoms will be related to urination. So this time the inflammation is with the bladder. So bladder inflammation will give you symptoms like urination. The patient will be urinating like 10, 15, 20 times, 25 times in the question. Painful urination. Suprapubic pain because bladder is over there, cloudy, strong smelling urine, hematuria because the bladder is inflamed. In the cases of bladder cancer, you will see even the direct clots in the urine. So nocturia, urination at night, the bladder is inflamed. So if when the urine will come in the contact with the inner layer of the bladder, so the bladder will not be able to tolerate it because it's inflammation over there. Yeah. Pyelonephritis, let's define it, or maybe let's see some question over the cystitis first. So because you just see the definition portion, so let's see some question. Let's hear from some patient. 12-year-old girl overcooled on suprapubic area, frequent urination in small portions, temperatures, Pasternetki symptom is negative. So guys, when Pasternetki symptom is positive, the problem is related with the kidney. So this is actually the costovertebral angle tenderness. What we do is we tap on the patient's backside near to the costovertebral angle, and the patient reports the pain. So the Pasternetsky sign is positive. What are over there on the costovertebral angle, near the costovertebral angle? Kidneys are present over there. So any problem with the kidney, so Pasternetsky will be positive. We are going to see it in pyelonephritis because in pyelonephritis the problem is with the kidney. This time in the cases of cystitis, the problem is with the bladder. So you can see the question is screaming about the urination painful and painful suprapubic area. So this is the profile of cystitis. Let's see what is pyelonephritis. It's a kidney infection, typically occurs when the bacteria ascend from the lower UTI, lower urinary tract infection, like from the bladder or from the urethra to the kidneys. Can be acute or can be chronic. When cystitis is there, so the bacteria is already had reached to the bladder, right? So the bacteria can now travel from the ureter to the kidney itself. Yeah. So in the cases of cystitis, as a complication, you can consider pyelonephritis is already a complication of bladder inflammation or cystitis. Yeah. So yeah, now we can read them. Urolithiasis. In the cases of kidney stones, we are going to see more blood in the urine. In the cases of acute pyelonephritis, high fever, Pasternetki positive. In glomerulonephritis, protein and hematuria will be there. Glomerulonephritis is simply the failure of the filtering unit of the kidney. So when the main function of the kidney is about the filtration. Yeah. So if the kidney is not able to filter well, so the proteins will get released in the urine. So more is RBCs will get released through the urine because they are not able to filter through the or get back to the blood vessels. So let's see it. Let's see some question. First, let's discuss about it very well. So glomerulonephritis, I just told the definition that it is the failure of the filtering unit of the kidney. So nephritic and nephrotic syndrome, I have created this table for you, so you can take a screenshot as well. So proteinuria, let's see. So in nephritic syndrome, the proteinuria is less than 3.5 gram per day. In nephrotic, O means O, proteinuria. Oh, nephrotic is proteinuria, so it is severe. The findings which you will see in the patient are more than 3.5 gram per day. Hematuria, so nephritic syndrome is characterized by hematuria and nephrotic syndrome is characterized by proteinuria. So if you remember just this thing itself, so the questions will be easier for you. However, I have included a atypical question. Rest of the question you are solved in the test center with this table itself. However, I have included a tough atypical question, something to remember about it. Edema will be mild in cases of nephrotic syndrome. It will be severe. Hypertension common, less common. Hypoalbuminuria mild or absent, marked. Causes nephritic syndrome is caused by the inflammation. For example, post-streptococcal glomerular nephritis. In such cases, you will be given the history of tonsillitis a week ago or two, and in the cases of nephrotic syndrome you will be seeing the damage of podocytes. So there and also the case of glomerulonephritis. I have included a atypical question here, so you can read the whole profile of the question, but one thing to remember here is when albumin in the last third line, that the albumin level when given 27 gram per liter. So remember that albumin 27 is high proteinuria. Okay, so you have to mark the nephrotic syndrome. This question we have seen. Let's hear the pathologies from patients itself. Let's go next. Some more things about cystitis. So you can read in the question number 8 that a young patient complains about the frequent urination, painful urination, urge to urinate at night. So you remember the suprapubic and lumbar area pain. Do not mug up the lumbar area pain with the Pyelonephritis or pyelonephritis. So suprapubic pain is given, urination symptoms are given in the question. What you are going to mark? Cystitis, yeah, the inflammation of the bladder. However, you can read the whole profile of the question. Next patient also complains about the man after overexposure to cold developed the acute pain in the lower abdomen and burning sensation which occurs at the end of the urination. Urination is 15 times in 24 hours. So you know from the introduction portion, guys, that when the urination is this much frequent, that the problem is with the urinary bladder. Yeah, so you are going to mark about the acute cystitis. Next patient, let's see the profile of pyelonephritis now. So in the pyelonephritis, fever, now the lumbar area pain will be there. That this Pyelonephritis which we highlighted just before, the costovertebral angle tenderness or pain, it will be highlighted very well in the questions. So as you can see in the patient, the proteinuria is mild here, right? So it is lesser than 3.5. So in the cases of pyelonephritis, what happens is mild proteinuria will be there, a little bit of WBCs will be there, like leukocyturia, a little bit of maybe more bacteria will be there in the urine because it's a bacterial infection. So next patient also complains about the pain in lumbar area, fever, leukocytosis, proteinuria, leukocytosis, bacteriuria. So these all are the findings given in by the patient, but one thing to remember here is the problem has persisted till 5 months from now. So 5 months, this is the case of pyelonephritis, and after hearing this 5 months you are going to mark chronic pyelonephritis, right? So I marked acute for it in the question before because we do not like to read the question very well. We all know that, yeah, but in the exam at least I would like to tell you that just in the exam read the question 2-3 times. You will have enough time to read it in the exam. So remember about that 5-month cases of chronic pyelonephritis. Let's hear the next patient. Next patient is 38-year-old complaining about that he got it after the overexposure to cold. Pyelonephritis is positive here. Sir, Pyelonephritis positive means what? Means their problem is with the kidney, and when there is bacteria in the urine, leukocytes in the urine, so what you are going to mark, sir? We are going to mark acute pyelonephritis. Next patient also complains about the pain in the lumbar region. Yeah, so lumbar pain is typical for acute pyelonephritis. Urine analysis will tell to you leukocytes are there, bacteria are there, urine contain the E. coli bacteria over there. So sir, we are going to mark the acute pyelonephritis. Yeah, so sixth patient, we haven't done about the sixth patient. So the patient complains about the sharp pain in the small of his back. So remember guys, small of his back is also the lumbar area. So in these cases we are going to see again the WBC, so urine protein will be there, but remember that this is not the characterized urinary protein for the nephritic or nephrotic. The question want to highlight about the bacteria are there. So ESR is elevated, leukocytosis is there, so you can remember about it that bacteria are there in the urinary profile of the patient, and this is the case of pyelonephritis. Next case is also about the pyelonephritis. Let's hear it from patient. The patient complains about the lumbar pain, the same thing, yeah, and the temperature is given, Pasternetki positive is given. So whenever Pasternetki is positive is given, you remember or know about it that the patient is having the problem with the kidney and not the lower tract infection. However, urinary findings are bacteria. Pyuria means WBC or leukocytosis again. So remember about it. Cystitis is inflammation of bladder with frequent urination. Pyelonephritis will be the kidney infection, severe, and fever will be severe as well. Let's move to the syphilis. Syphilis is a STD which you know that caused by Tryptonema pallidum. Let's see the stages of it. Stages are, in the primary stages you are going to see the rashes over the genital, mouth and rectum. In the secondary syphilis you are going to see the rash move to the palm and soles. In the latent syphilis no symptoms will be there, but bacteria is still there in the body. So whenever immune suppression will be there, like in the cases of HIV, so the bacteria will get a chance to get in the active phase. Tertiary syphilis is a serious complication affecting the various organs like the cardio organs, so there will be organs failure will be there. So you can take a screenshot of these stages so that you remember. Also remember that Chancery, these rashes of syphilis are termed as Chancery in the medicine terms, and you can see the rash size. However, it's barely important for KROK, but I have a shorter version for you. So in primary syphilis, the rash will be genital, mouth and rectum. In the secondary, it will move to palm and sole. In the latent, there will be no clinical symptom. In the fourth degree, there is all organ involvement is there. So let's hear it from the patient itself. The first patient complains about the skin rash appeared a week ago, doesn't cause any problem on palm and soles. So guys, remember that palm and sole rash is the case of secondary syphilis, and as it says that papules are reddish, dense and covered with the keratinous squamate. So nothing typical given in the question about syphilis, but if you remember that in the secondary syphilis the rash is on the palm and sole, as you have seen in the table. So you can take the screenshot of shorter version as well to remember it very well. So you see the palm and sole rash mark the secondary syphilis. Next patient is also complains about painless sores on the penis. So which sores he is talking about? He is not talking about herpes here, yeah, he is talking about the chancery which we just learned. And the size is given in this question, that's why I decided to include the size of the rash in the question. So 0.5 centimeter diameter with the dense infiltration. So 0.5 rash size is in the primary syphilis, but sir there is also the sores were ineffective on the inner layer. Okay, you will understand the question now, that rash size is given, painless sores on penis, on the genital rash is the case of primary syphilis, right? And let's hear it from the next patient. Next patient complains about there is a positive blood test resulted in the positive Wassermann reaction. So Wassermann reaction and sedimentation reaction, thrice Tryptonema pallidum test. So these are the findings related to the syphilis. So these tests are related, Tryptonema pallidum test and Wassermann reaction are related to the syphilis, and as the patient says, no clinical manifestations were found. So this is the case of early latent syphilis, yeah. So next patient complains about ulcer on penis, painless round erosion, include this and this diameter. However, the diameter is okay, this is typical for primary syphilis. Diameter versus dense bottom, even the edges without edges. So you know that ulcer on penis will be the case of primary syphilis. The rash on genitals, even the size is given here. So if you can remember the size, then remember it. If you cannot, then still you will be able to solve the question easily. However, In the primary syphilis, the rash is from 0.5 to 2 centimeter. In the secondary syphilis, the rash is from 1 to 3 centimeter can be there. So nothing demarcation about the size of the rash, but it was given in the question, so that's why I decided to include it in the introduction portion itself. So next question is atypical. Sir, why it is atypical? Let's hear it. Sir, the rash is which the woman is complaining about is papular rash, painless, no itching, and clearly separated from the healthy skin, disappeared by its own without treatment, ulcer on labia majora. So we know that the ulcer on labia majora will be the case of genital rash, and it will be termed as primary syphilis. However, good news for you is that primary syphilis was not given in the question, so I decided to go with the closest best answer. Other pathologies were given in the question like herpes and blah blah, you know about that. So I just wanted to highlight that this is the case of primary syphilis. However, in the option only secondary syphilis was given. So next patient is having the symptoms of this and this with clear margins, the ulcer on the lower lip with the labial lip, the talking about the vaginal lips, so clear margins. And it says that what lab test you will do for the syphilis. So you know from the last question itself that tryptopnema palladium test is done for the syphilis. Yes. So this is it with this video. If there is something which you did not understand, let me know in the comment section, and subscribe to my channel for easiest crash course of the KROK 2 exam, and share it with your friends. And see you in the next video. Have a nice day.